Hey everyone, today we're going to talk about something that, let's be honest, affects every single one of us at some point. Vulnerability, especially when it comes to healthcare. It's this feeling we've all had, but maybe we just don't have the right words for it. Well, that's what we're going to do today. We're going to find those words.
So let me ask you this. Have you ever been there? You're sitting in a doctor's office or maybe a hospital room, and there's all this medical jargon flying around, the stakes feel incredibly high, and you just feel completely lost, overwhelmed, maybe even a little powerless. That feeling is exactly what we're diving into today. Okay, so we're going to take that feeling, that really personal experience, and give it some structure. The idea here is to build a framework, a new way of seeing vulnerability, not just as an emotion, but as a really critical concept in bioethics.
So what is vulnerability, really? At its most basic, it's just the capacity of being harmed. But what's so powerful, and what you see right here, is where the word comes from. It's from the Latin vulnus, which literally means wound. And that's such a strong connection, isn't it? It reminds us we're talking about the potential for real harm. Physical, emotional, social, you name it. Now, in the world of bioethics, this gets a little more specific. It describes a state where a person is less able to protect themselves, and because of that, they're more likely to be taken advantage of or to have their rights just violated. And this part is crucial. We're not talking about personal weakness here. We're talking about a risky situation. And wherever there's risk, there has to be protection.
Okay, so how do we actually spot this risk and protect people from it? Well, lucky for us, there's a tool for that. We're going to look at a framework that breaks vulnerability down into 7 different types, giving us a lens to see it all more clearly.
It just makes sense, right? To protect someone from harm, you first have to be able to see that harm clearly. A bioethicist named Kenneth Kipnis developed something he called a bioethical taxonomy, which sounds kind of academic, I know. But just think of it as a powerful lens. It's a tool that helps us diagnose the different facets of vulnerability so we can actually know what we're dealing with.
And here it is. This is the whole lens. You can see the 7 types Kipnis laid out: cognitive, juridic, deferential, social, situational, medical, and allocational. This table is basically our roadmap for the next few minutes. We're going to unpack what each of these means and how they point to different kinds of harm.
All right, let's start looking through this lens one piece at a time. First up, cognitive vulnerability. This one's pretty straightforward. It's when someone has a harder time making rational, informed decisions. A really clear example is a patient with dementia who's trying to make sense of a complex treatment plan.
Okay, next on the list is juridic vulnerability. This happens when someone is under the legal or official authority of another person or an institution. You know, the classic example is a prisoner. Their healthcare choices aren't entirely their own. They're constrained by the authority of the prison itself. Now this next one, is so common, you've probably seen it or even felt it yourself. It's called deferential vulnerability. This is when you defer to someone's authority not because they have any legal power, but just because you feel like they do. Think about a patient who's a little intimidated by their doctor, so they don't speak up or ask questions, even when they're worried. That's it, right there.
Then we have social vulnerability. This one is all about belonging to a social group that might be devalued or discriminated against. So, an immigrant, for example, might face prejudice that actually affects the quality of care they get. It shows how society's biases can create very real harm.
And what about situational vulnerability? This is all about the practical, real-world stuff. It's when your situation, your environment, creates barriers to getting care. A perfect example is an elderly person who simply can't get to their appointments because they don't have a car or reliable transportation. The problem isn't them, it's their situation.
All right, let's wrap up our list with 2 types that are often driven by desperation. First is medical vulnerability. This is when a patient is so sick with so few options that they become willing to try a really risky experimental treatment. And then you have allocational vulnerability. This is when someone lacks basic things like money, and they might join a clinical trial just to get the payment. In both cases, their tough circumstances are what make them vulnerable.
So, there you have it. We have our lens. We can now put a name to these different kinds of risks. But look, this isn't just some academic exercise. Why does this actually matter? Let's talk about the real-world stakes, where this potential for harm becomes all too real.
And this is a great way to see how context is everything. Think about it. In a research study, the big worry is making sure someone isn't pressured or swayed into participating. But in just regular day-to-day healthcare,
The focus shifts to that built-in power imbalance that exists between nearly every patient and their doctor. I mean, you are literally relying on them for your health and well-being.
And here's where the rubber meets the road. This is where the harm actually happens. Stereotypes can literally change the treatment someone gets. Fears or biases against certain groups, like ex-convicts, can put up huge walls to getting care. And the really tragic part is that the people who need help the most are often the ones who have the hardest time getting it. You can see how things like poverty or lack of transport just pile on, creating this vicious cycle that's tough to break.
Okay, seeing the problem is one thing, but it's not enough, right? We can't just point out vulnerability. We have to do something about it. So let's shift gears and talk about a real, practical action plan. What can we actually do to lower these risks and make healthcare safer for everyone?
And here are 4 steps that are, well, they're not rocket science, but they are incredibly powerful. Number 1, explain things clearly. Ditch the jargon. Make sure people actually understand what's going on. 2, ensure access. Make sure people can physically get in the door and get around. We're talking wheelchair ramps, clear signs, basic stuff. 3, actively listen. Treat patients like human beings, not just a checklist of symptoms. And finally, number 4, be an advocate. Stand up for your patients. Report abuse. It's about having their back. Simple ideas, but they require real, constant effort. And look, this isn't just a job for doctors and nurses. This is on all of us. Protecting people who are in a vulnerable spot, that's a basic responsibility we all share. It's really a measure of who we are as a society.
And this isn't just a nice idea. This is a globally recognized principle. Just look at this quote from the UNESCO Declaration on Bioethics and Human Rights. It says it right there in black and white. Individuals and groups with special vulnerability should be protected, and their personal integrity must be respected. That's a powerful statement. So when it comes to healthcare workers, the message is crystal clear. This is not optional. It is a legal and a moral obligation. They have to be aware of their own biases, they have to report abuse when they see it, and they have to be a consistent voice for their patients.
So, we've given you this lens. You can now see the different shapes vulnerability can take. The question that remains isn't really for me, it's for you. Now that you can see it more clearly, what are you going to do to help protect those who need it most? Thanks for joining us.